Good afternoon, good evening, and good morning, all friends and viewers. Welcome to my live stream. I will continue to my topic about health assessment in nursing. Under these health assessments in nursing is the assessments of the Frail elderly client. Now let's proceed to continue. Understanding the HCFA guidelines for potentially inappropriate medications in the elderly, optimizing prescribing in long-term care. Severe adverse outcome, amitriptyline, elavela, chlordiazepoxide, amitriptyline, limbitrol, and amitriptyline triavil. Summary of prescribing concern is strong anticholinergic and sedating properties. Rarely, the antidepressants of choice of the elderly may be used for neurologic pain if evaluation of risk versus benefit is documented. Barbiturates, all except phenobarbital, summary of prescribing concern, higher incidence of side effects than most other sedatives and hypnotics used in the elderly. Highly addictive, used only to control seizure. Ting benzodiazepines, chlorodiazepoxides, Librium, chlorodiazepoxides, amitriptyline, limbitrol, glidinium, chlorodiazepoxides, libraxdiazepam, Valium, and flurazepam dalmine. Chloropromide, Japanese. Summary of prescribing concern. Chlorodiazepoxides, diazepam, flurazepam, and other long-acting benzodiazepines have a long half-life in the elderly, produce prolonged half-life in elderly which can use prolonged hypoglycemia, also cause SIAD o SIADH. Severe adverse outcomes, dicyclomine bentyl, iosocyanine, levsinex, propateline, probantin, belladonna, alcohol, librax. Summary of prescribing concern. GI antispasmodics are highly anticholinergic and generally tolerated by elderly is questionable. Best avoided in the elderly, especially for long-term use. Use for 7 days or less and not more frequently than because the digoxins, lanoxins, greater 0.125 milligrams a day. Summary of prescribing concerns for the elderly. Because of decreased renal clearance in the elderly, avoid doses greater than 0.125 mg except when treating atrial arrhythmias. Severe adverse outcome of prescribing concern for the elderly. Negative inotrope that may induce doxepin sine severe adverse outcomes, doxepin sine summary of prescribing concerns for the elder. Strong anticholinergic and sedating properties, rarely the antidepressants of choice in the elderly. Meperidine, Demerol, prescribed concerns for the elderly. Not an effective oral analgesics. Severe adverse outcomes, miltau, inquanil. Summary of prescribing concern for elderly. Highly addictive and sedating aldomet, methyl-dopa, aldoril, methyl-dopa hydrochlorothiazide, pezin, toluene, Summary of prescribing concerns for elderly may cause bradycardia and exacerbate depression in the elderly. Alternate antihypertensive are preferred analgesics causing more CNS side effects than other narcotics drugs, including confusion and hallucinations, mixed agonists and antagonists. Severe adverse outcomes sa ticlopidine, ticlid, o summary prescribing concerns for elderly no better than aspirin is preventing clotting and considerably more toxic. Avoid in the elderly, review not necessary if used in patients who have a stroke or have evidence of strokes precursors, transient ischemic attacks, and cannot tolerate aspirin. Now let's proceed to 1030-10 continuation. But this time is about understanding the HCFA guidelines for potentially inappropriate medication in the elderly, optimizing prescribing in long-term care. Less severe adverse outcome. Diphenhydramine Benadryl, summary of prescribing concern. Potent anticholinergic properties should not be used as sedative. To treat allergic reactions, use lowest dose possible and with great caution. Do not necessary if used for 7 days or less and not more frequently than every 3 months. For treatment of allergies, dipyridamole o Pexantine. Summary of prescribing consent for elderly frequently causes orthostatic hypotension. Use the elderly should be avoided. Less severe adverse outcomes, ergot, mesylate, hydergine, cyclandelate, cyclopasmol, other cerebral vasodilators, antihistamine, such as single and combination preparations containing chlorperamine, chlorotrimethone, diphenhydramine, Benadryl, hydroxyzine, Vestarel, Atarax, Periatin, cypropedatin, HCl, promethazine, Penegran, tripelenamine, PBZ, and dexchlorapine, poloramine. Indocin, indomethacin, indocin SR, indomethacin. Summary of prescribing concern for elderly. Have not demonstrated effectiveness in the treatment of dementia or any other condition. Potent anticholinergic properties. Use cough and cold substitutes without antihistamine. Review not necessary if diphenhydramine is used for 7 days or less and not more frequently than every 3 months for treatments of allergies. More CNS side effects than other NSAID and said and therefore should not be used in the elderly, short-term use, etc. 1 week week is accessible for treatment of gouty arthritis. Metocarbanol, robaxins, carisoprodol-soma, chlorozazone, Paraflex, metaxalone, escalaxin, flexeril, cyclobenzaprine, dantrolene, dantrium, and orphanadrine, Norflex, Norgesic. Summary of prescribing consent for elderly. Most muscle relaxants are poorly tolerated by elderly, leading to anticholinergic side effects, sedations, and weakness. The effectiveness at doses tolerated by the elderly is questionable. Review not necessary if used for 7 days or less and not more frequently than every 3 months for symptoms of an acute self-limiting condition. Phenylbutazone, butazolidine, that is the less severe adverse outcome. Summary prescribing concern for elderly may produce serious hematological side effects, blood disorder, and should not be used in the elderly. Less severe adverse outcome, Receprin, Serpacil, Resperpin combinations product. Summary of prescribing concern for elderly may produce serious hematological side effects, blood disorder, and should not be used in the elderly. Might cause depression, sedation, and orthostatic hypotension. Safer alternative exist. Trimethopenzamide Tigan can summary of prescribing concern for elderly can cause extrapyramidal side effects, low effectiveness as antiemetic drug. Aldomet, Aldoril, Indocin Senior, Flexeril, and Periactin are registered trademarks of Merck and Company Corporation. All other brands listed are trademarks of the respective owner and not of Merck and Company Incorporated. It is important to note that most packaged circular produced by drugs manufacturers do not include language identical to the statement presented here, although the adverse effects that these drugs can produce are generally listed in the package circular. These as well are warnings and contraindication must be approved by the regulatory agency and in general are not based on consensus or surveys. Before prescribing Aldomet, Aldoril, Indocin Senior, Flexeril, and Periactin, please read the company full prescribing information. CNS indicates central nervous system and SAID indicates no steroidal anti-inflammatory drugs. CN indicates syndromes of inappropriate antidiuretic hormone. Adopted from BMH 1997 explicit criteria for determining potential inappropriate medication used by the elderly and update Archivist Internal Medicine. Biographic data. Cultural norms were not always as informal as they are today. Many of the elderly grew up when older people were not addressed by their first name except by those very close to them. One should always begin the interview by addressing an older person of Mr., Miss, Sis, or Miss, or with the appropriate titles such as Reverend or Doctor. In general, younger people today are more likely to feel comfortable sharing personal information with regard to finances, personal like I dislike, and feelings than are their older counterparts. Many other people are also aware of their vulnerability with regards to scam and fraud, thus are reluctant for good reasons give up and personal information. An important maxim geriatric care is collect to no more information than essential for optimal care. History, present health concerns, current health status. The subject data collections process similar for every client regardless of age involved for their exploring any signs of symptoms of illness or functional decline detected by nurse or reported by the client. It may instances the nurse will continue to collect health history during the head-to-toe assessment. Use the called SPA mnemonic as guideline. For information collect in the additional, the following help elicits important information. Called SPA, character. C means character, describe the signs of symptoms, how does it feel, look, sound, smell, and so forth. O means onset, when did it begins. L means locations, where is it, does it radiate. D means duration, how long does it last, does it recur. S means severity, how bad is it. P means pattern, what makes it better, what makes it worse. A associated factors, what other symptoms occur with it. Review of system. It is essential the pertinent subjective data be collected for each body system. The additional nursing history questions listed in the following sections for each system are special concerns of the frail elderly. That is the review of system. Skin and nails question and rationale. Over the past year, what changes have you noticed in your skin, hair, nails? Have any rashes developed after you took new medication? If so, what was the medication? Rationale, certain changes including rashes result from allergic reactions. Others such as inflammation may result from infection, cancer. Questions, do you have problem with dry or itchy skin? What is your routine in bathing? How do you care for skins? What type of moisturizers do you use? Rational, dry itchy skin may result from the drying properties of soaps or alcohol-based after-bath preparations. Do you have history of ulcers, open wounds on your feet or lower legs? Rationale, elderly clients with skin ulcerations such as those related to diabetes or peripheral vascular disease should be monitored for infection. They should be referred to podiatrist every 3 to 6 months, swab nails clip and any corns of calluses. Remove professional to prevent infection and other complications. Smoking cessation should be encouraged for anyone with ulcer resulting from arterial insufficiency. See Chapter 19 for more information. Eyes and vision question and rationale. Do you see better one eye than other? Have you noticed any changes in your vision? If so, describe any problems night vision. Radar vision is one eye is a warning signs of macular degeneration, a leading cause of blindness, and elderly people in chronic form of macular degenerations. The client may need a referral to a low vision specialist or may benefit from visual aids such as magnifying devices, large material taking books. Early laser treatment may retard the loss of vision. Do you ever see small specks or clouds moving across your fields of visions? Rationale, with aging, tiny clumps or gel may develop with the eyes. These are refer. Shout out to Maribel Rian. Shout out. Good afternoon. Okay. Do you ever see small speck or clouds moving across your field of vision? Rationale, with aging, tiny clumps of gel may develop within the eye. These are referred to as floaters. New floaters and increase in frequency or floaters associated with flashes of light may be a sign of retinal detachment, which is an indication for immediate referral to an ophthalmologist. Early detections and treatment may be crucial in preventing blindness. Do your eyes feel dry or irritated? Do they tears excess? Physical examination may validate ectropion or entropion. Referral to an ophthalmologist may be warranted depending on severity of symptoms. Ear and hearing question and rationale. How well do you hear? Have you noticed any hearing loss recently? Do you have difficulty hearing someone if there is a lot of noise in the background? Have you ever had to have earwax removed? Rationally, thinning of tympanic membrane and accumulations of ear may result in conductive hearing loss. If accumulated cerumens accounts for hearing loss, the loss is usually gradual. Clinical tip: irrigation and cerominolic, minolitic agents are contraindicated for clients with perforated tympanic membranes on ear infection. Do you ever feel especially uncomfortable or confused because you cannot hear as well as you would like? Here's a question. That is the question. And rationale, many elderly people, especially those with dementia, are at risk for becoming withdrawn, anxious, or increasing confused as hearing impairments progress. Head and neck question and rationale: do you have intermittent or a continuous pain in the head of neck region? Rationale: various disorders associated with Frail elderly adults such as arthritis are accompanied by pain in the heads and neck, mouth, and throat. Questions: do you limit kinds or amounts of foods you eat because of problem with your teeth or dentures? Example, beating apples or chewing meat. Are you worried or concerned about problems with your teeth, gums, or dentures? Are your teeth organs sensitive to hot, cold, or sweet? Rationale: oral health is vital component as a good nutrition, socialization, and positive self-concept. Untreated oral health problems are a common cause of pain and discomfort that may interfere with chewing, swallowing, and digestions and will contribute to any inadequate nutritional intake. A key prevention is early detections of older adults at risk with a valid and reliable oral health assessment. Okay, wait for a while. Okay, thank you for waiting. Now let's continue to our discussion. Okay, ear and hearings. How well do you hear? Have you noticed any hearing loss recently? Do you have difficulty hearing someone since there is a lot of noise in the background? Have you ever had to have earwax removed? Rationale, thickening of the tympanic membrane and accumulations of earwax may result in conductive hearing loss. If accumulated cerumen accounts for hearing loss, the loss is usually gradual. Clinical tip, irrigation which perforated tympanic membranes or an ear infection. Do you ever feel especially uncomfortable or confused because you cannot hear as well as you would like? Rationally, may elderly people, especially those who dementia, are risk for becoming withdraw anxious or increasingly confused as hearing impairments progresses. Head and question and rationale, do you have intermittent or continuous pain in the neck region? Rationale, various disorders associated with frail elderly adults such as arthritis are accompanied by pain in the head and neck area. Mouth and throat question and rationale. Do you limit the kind of amount food you eat because of problem with your teeth and dentures? Example, biting apples or chewing meat. Are you worried or are concerned about problems with your teeth, gums, and dentures? Are you teeth or gum sensitive to hot, cold, or sweet? Rationally, oral health is a vital component of good nutrition, socialization, and a positive self-concept. Untreated oral health problem area a common cause of pain and discomfort that may interfere with chewing, swallowing, and digestion and will contribute to any inadequate nutritional intake. A key to prevention is early detection of older adults at risk with a valid and reliable oral health assessment tool display 30-11. Do you ever feel like you're choking when you drink water or feel like food is catching in your throat? Rationale, dysphagia, inability to swallow easily is frequent problem associated with neurological condition and anytime food is not sufficiently chew or there is insufficient saliva to mix with food. Clinical caregivers and dysphagic people may assist with swallowing by preferring semi-solid food and fluids of padding consistency, alternating solid food with thickening food, and encourage the clients to lean slightly forward and tuck the chins under to prevent or gagging. According to 30-11, the Geriatric Oral Health Assessment Index indicate in the past 3 months how often you feel the way described in each of the following statements. Circle one answer for each. 1, 2, 3, 4, 5. Number 1, how often do you limit the kind or amount of food you eat because a problem with your teeth or dentures? Number 1, always, 2, often, 3, sometimes, 4, seldom, 5, never. Number 2, how often did you have trouble biting or chewing? Number 1, always, 2, often, 3, sometimes, seldom, never. Number 5. So 1, 2, 3, 5, always, open, sometimes, seldom, never. So I will read the question. So you should answer 1, 2, 3, 4, 5. Alright? So number 3, how often were you able to swallow comfortably? 1, 2, 3, 4, 5. How often have your teeth or dangers prevented you from speaking the way you wanted? 5. How often were you able to eat anything without feeling discomfort? 6. How often did you limit contacts with people because of the condition of your teeth and denture? 7. Were you pleased or happy with the looks of your teeth and gums and dentures? 8. How often did you use medications to relieve pain or discomfort from around your mouth? 9. How often were you worried or concerned about the problems with your teeth, gum, or dentures? How often did you feel nervous or self-conscious because of problem with your teeth, gums, or dentures? 11. How often did you feel eating in front of people because of problems with your teeth or dentures? 12. How often were your teeth or gum sensitive to hot, cold, sweet? Nutrition, question and rationale. Have you experienced any changes in your appetite in the past 6 months? If the response indicate a decline in appetite, continue with the following questions. When did you first notice a decline in appetite? Did you have any other health problems at about this time? Did you start taking any new medication at this time? Rationale, a loss of appetite is a nearly universal factors of both physical and mental disease in the elderly because the body's housing is smaller energy. The minimum caloric intake thus decrease in old age. Even healthy older adults consume only as estimated 1,200 to 1,600 calories per day. This has led to a general consensus that older adults need to nutrients-dense foods to ingest enough essential nutrients. There is a less consensus with regards to how dietary recommendations should vary. For the 75 plus age group than as to what indication and factor place an older adult at risk of malnutrition and dehydration. Besides appetite loss, additional questions to consider when assessing nutritional status include: are you in pain, which diminishes appetite? Is your mobility limited? Do limitations affect shopping for and preparing food? Are you impoverished? Has there been a recent loss of a spouse or other close relative or friend? It is the client's housebound, institutionalized, cognitively impaired, is feeding. Okay, thank you. Maribera Plerarian, shout out. Institutionalized, cognitively impaired, is feeling acquired. Do other factors such as depression, chronic illness, dementia, fever, diarrhea, vomiting, dysphagia, or infections affect nutritional status? Rationale. Thank you po. Certain problems, dysphagia, immobility, and cognitive impairment are more common among the very old than among middle-aged adults. Certain chronic diseases such as cancer and rheumatoid arthritis are showing an increased incidence in the elderly. This chronic disease causes an increased inflammatory cellular components associated with anorexia and fatigue. Any illness or medication that causes nausea and fatigue then can contribute to loss of appetite. This is why the very old are especially vulnerable to the bias of acute care medical system that inadequacy manages pain caused by chronic disease, etc., osteoarthritis, and osteoporosis. A certain degree of anorexia always accompanies pain, especially chronic pain. Toxic level of drugs must always be suspected when appetite loss in sudden severe. Question: can you describe what you eat in an average day? On a day when your appetite is less, how would your eating habits change? Rationale: assessment of nutritional status as a twofold purpose in the very old person. You should ask about eating habit and any recent changes in them when older adults seek care for an acute episodic illness or as part of comprehensive baseline assessment. A sudden loss of appetite is most often a symptom of disease or an adverse medication effect. As a part of comprehensive assessment, a nutritional screening tool, display 30-12, can be used to identify the need for treatment. Recommendations with regard to specific dietary adjustment, assistance with eating, shopping, or meal preparation are further assessment of specific conditions such as dysphagia or cognitive impairment. A 3-day food diary with 1 day being is a weekend day is the most reliable method of obtaining a diet history. Older persons commonly underestimate the amount of portions of food they eat. Among those 75% and older, An estimated 40% of men and 30% of women are at least 10% underweight. Nearly 50% of persons age 65 and older are clinically malnourished at the time of admissions to hospital, and two-thirds are malnourished at the time of discharge. Amelia 2001, a screening tool may be helpful to identify those at risk for being malnourished. 30-12 NSI checklist to determine your nutritional health. The older adult fills out the following question which have associated points. I have an illness or conditions that made me change that kind or amount of foods I eat. Yes, 2 points. I eat fewer than 2 meals a day. Yes, 3 points. I eat few fruits and vegetable or milk product. Yes, 2 points. I have 3 or more drinks, beer, liquor, or wine almost every day. Yes, 2 points. I have tooth or mouth problems that make it hard to me to eat. Yes, 2 points. I don't always have enough money to buy the food I need. Yes, 4 points. I take 3 or more different prescribed or OTC drugs a day. 1 point. Without wanting to, I have lost or gained 10 pounds in the last 6 months. 1 point. 2 points. I am not always physically able to shop, cook, and feed myself. 2 points. Total nutritional score, scoring 0 to 2 indicates good nutrition. 3 to 5 indicates moderate risk. 6 or more indicates high nutritional risk. Hydration. Question and rationale. How much fluid do you think you drink each day? Maria, out muna ako. Sige po. Loss of appetite almost always coexists with inadequate hydration. Decreased thirst sensation is common with aging. And decreased mobility makes it less possible for the frail elderly persons to respond to an elderly diminished sense of thirst. Drug use may contribute to dehydration as well. For example, diuretics are widely used in treating cardiovascular and renal disease, as are fluid restriction. Unfortunately, when the body need for fluid increase, as it does with infection and concomitant increase in metabolic rate, adjustments are not always appropriately made for functionally dependent frail elderly people. Thank you po, salamat. Thus, loss of appetite is both a symptom of an acute or chronic medical condition as well as a risk factors for malnutrition and dehydration. That purpose of threat to overall health and well-being. Functional risk factors that signals the needs for hydration assessment are the same as for malnutritional with addition and urinary incontinence. Nose question and rationale. Have you experienced a change in your ability to smell or taste? Rationale. This ability to smell and taste decreases with age. Medications can also decrease sense of smells and taste in older people. Thorax and lungs question and rationale. Do you ever experience shortness of breath? If so, it is related to activity. Specific questions about endurance, stair climbing, or activities of daily living or necessary for quantifying the extent of the problem. That is occur rest or when lying down. How many pillows do you use? Any pain with breathing? Rationale. Dyspnea is a very common reason for emergency room visit and is frequently reported. Symptoms associated with common illness among elderly clients. This illness include COPD, asthma, lungs cancer, and heart failure. Older adults with chronic respiratory or cardiac problem who experience some constant degree of dyspnea are unlikely to seek care of dyspnea unless there is a change in functional capabilities related to breathing. Therefore, it is important to ascertain to what degree dyspnea affects daily function. Question and rationale, do you see to be breathing faster, sweating? Do you experience anorexia, loss of appetite, or fatigue? In the Frail elder, an increase in respiration, sweating, or overall malaise may be the only indications of a respiratory problem. Kennedy Malone, etc. 2000. Do you have a recurrent cough? Does it ever have blood in it? Do you have used tobacco or have you in the past? Rationally, a recurrent cough, fatigue, weight loss, and shortness of breath, and productive cough, sometimes blood thinning, are hallmarks of lung cancer. It is the most common cause of cancer associated death in the United States. The incidence increased with aging, second most common type of cancer in men over 75, with incidence rising in women. Have you experienced weight loss or changes in your health along with your cough? Rationally, weight loss, night sweats, or changes as respiratory status such as coughing may be signs of tuberculosis, TB, debilitated. Elderly people are increased risk of TB. In addition, glucocorticosteroid, glucocorticosteroid therapy, and nutritional exacerbating in the chance of reactivating dormant TB infection. Have you received the pneumococcal vaccines within the past 6 years? Do you get annual flu vaccines? Rationale, pneumonia is the most common cause of infections-related deaths in the elderly. The pneumovax is recommended once lifetime for those of over age 65 and every 6 years for high-risk patients. Debilitated and institutionalized elders are particularly at risk for serious influenza-related illness. Heart and blood vessel, impair in circulations and other conditions to aging increase elderly client risk for false relevant questions to ask when compiling health history data follow. Question and rationale. Do you ever feel lightheaded or dizzy when you get up from chair or the bed? Rationale. If the client reports dizziness, you may need to perform a safety assessment to evaluate a fall history of potential falls associated indicated in a get up and go to test see physical assessment sections which help to assess gait and balance or performance oriented environmental mobility screens. Bowens display 30-13. Do you have any discomfort in your legs with activity? Would you like describe the discomfort as pain, cramping, itching, fatigue, or weakness? In the calf, do your hips, thighs, and or buttocks hurt with ambulation? If so, how can you walk before the pain occurs? Does the pain go away with rest? Rationale, these symptoms are associated with intermittent uh, claudication, Do you think it takes excessively for time to be stopped bleeding after you get cut or scratch? Some medication used for cardiovascular disease and some coagulation disorder are associated with extended bleeding times and decreased clotting ability. Uh, Abdomen. Question and rationale. Do you ever have heartburn, indigestion, chest pains, high gas, belching gas? Rationale. Heartburn, also called gastroesophageal reflux disease. GERD it is most severe from can mimic angina pectoris and can irritate vocal cords and cause of hoarseness, coughing and wheezing, heartburns, high gas, belching gas, vomiting, and sores or better taste generally occur after a meal. It may be worse if the client lies down, decrease esophageal motility in commonly related to central nervous system CNS disease. Diabetes mellitus central nervous system CNS disease. Diabetes mellitus of thyroid disorder. Relax may result from decreased lower esophageal sphincter, less pressure or a result of age of alcohol, nicotine or other drug use including nitrates, calcium channel blockers, theophylline and anticholinergics, antidepressants, and benzodiazepines. Do you have any trouble with digestion, vomiting, rational, early satiety, or vomiting of undigested food? May indicate an excessive delay in gastric emptying. This may be seen in Parkinson's disease and diabetes mellitus. Note, a warning sign may indicate deteriorating blood glucose control in elderly diabetic patient. Clinical tip: bulk forming agents taken before meals may contribute early society acute gastrointestinal abnormalities such as cholecystitis and peritonitis often produce much less severe symptoms, pain and mild changes in lab values in their very old, often delay a timely diagnosis. Once again, the more subtle symptom as discussed in the sections on geriatric syndromes may be the presenting symptoms of life-threatening problems such as peritonitis or sepsis. Do you suffer with any pain in the upper right portions of the abdomen? Pain may be related to cholecystitis and the formation of gallstones, which occurs more frequently in the age. However, only mild right upper quadrant pain, vomiting, and elevations in bilirubin and hepatic enzymes level may be seen. Fever is seldom a symptom of cholecystitis. 30-13 performance-oriented environmental mobility. Location, maneuver, normal, impair. So, yung normal and impair box, i-check lang. So, locations, bedroom, maneuver, ambulation, straight line, turning, chair, transfer on to off. Standing balance, eye opens, eye closed, sternal nudge, bending down, bend, transfer on to off. Bathroom, ambulation, straight line, turning, toilet, transfer on to off. Toilet, hygiene, hallway, ambulation, straight line, turning distance. Falls in older persons, prevention and management. Ay, all right. Urinary continence. Urinary continence. Incontinence can be manifestations of a chronic problem or an acute reversible ones. It can also be multifactorial and in the result of combination of factors such as immobility, dehydrations, medication, infection, altered cognitions, or weakness and lethargy. Question and rationale. Many illness and medications can cause problem with urine control. This is not normal just because one is getting older, but is the common problem. Have you ever experienced anything like this? Rationale. Loss of bladder function or control can be embarrassing and demeaning problem, so it is sometimes best to introduce the topic with questions such as this. Many older adults subscribe to the predominant myth the problem with bladder control are normal and expected part of aging. Yet this year is not expected part of aging. Incontinence is often associated with chronic conditions such as stroke, multiple sclerosis, prostatitis, and urinary tract infection. It may also be the result of fecal infection, constipation, and adverse drug effects of urinary tract infection, UTI. Without a systematic method of identifying and evaluating continence, many people live with underlying conditions undiagnosed and untreated. The first step, therefore, involves recognizing that incontinence it is abnormality and requires assessment. Do you ever have any urine leakage and problems controlling your urine flow? Urinary incontinence is in an involuntary loss urine with or without warning, which is sufficient enough to be problem between 50% and 30% of older adults living home and up to 50% of nursing home residents are incontinent. That success of treatment measures depends on a comprehensive assessment for the purpose of determining of all of the etiologic factors responsible. Although incontinence is most successfully approached from a multidisciplinary perspective, the nurse plays a major role in assessments, collaboration, and management. How long has the leakage or use clients' descriptive words been going on? Has it ever suddenly gotten worse? A new onset incontinence or exacerbations of should mostly definite raise questions about infections. Is the hospitalized elder? UTI ranks with high suspected cause for any new onset incontinence. UTI is the most common hospital-acquired bacterial infections. UTI must also be concerned for elders of home in long-term care because it is the most frequent source of bacteremia for these people. UTI is particularly perplexing in elderly clients because it presents in such a typically way without fever or elevations in white blood cells counts or dysuria or urinary frequency. Even more common symptoms of UTI in the frail elderly persons may in confusions, lethargy, anorexia, nocturia. What activity are associated with your loss of urine control? The client's activities during episodes of incontinence may help to determine the type of incontinence and therefore its treatment. CD plus 30-14 for a description of the kinds of urinary incontinence. According to 30-14, understanding the urinary incontinence assessments, type of incontinence, these signs symptoms associated with the voluntarily loss of urines have been clustered into three categories: urge, stress, and overflow. Incontinence, any one of your combinations of all three types may be present in individual. Voiding diaries are useful for determining the type of incontinence that is occurring based on the amount, timing, and associated symptoms of incontinence episodes. Voiding diary, time, drinks, voiding. Kind, how much, how many times, how much. 6 to 7 a.m. kinds coffee, how much 2 cups, how many times 1, how much medium 7 to 8 a.m. Kinds orange juice, how much 1 glass, how many times 2, how much lots. 8 to 9 a.m. Orange juice. 9 to 10 a.m. orange juice, how much 1 glass, 1 glass, how many times 1 1, how much little. 10 to 11 a.m. o 1 glass, it's 1 glass 1 medium. Time, leaks, accidents, strength, urge, activities times leaks. 6 to 7 a.m. is strong. 7 to 8 a.m. is strong. Activity of the time of leak, no leak. 8 to 9, frying egg. 9 to 10 a.m. none. 10 11. Urgent incontinence. Urgent incontinence is the involuntary loss of urine associated with unapproved and strong desires to void, is frequently caused by a neurologic disorder such as cerebrovascular accident CVA or multiple sclerosis MS, which impairs the ability of the bladder or urinary sphincter to contract and relax. Stress incontinence. Stress the incontinence in the involuntary loss of urine during cough, sneezing, and laughing or other physical activities that increase abdominal pressure in women. Stress incontinence may result from weakened and relaxed muscle from the combined effects of aging superimposed of the effects of children. Note, atopic vaginitis from estrogen deficiency usually result in symptoms of urge incontinence as well as stress incontinence, mixed incontinence, overflow incontinence. Overflow incontinence is the involuntary loss of urine associated with overdistensions of the bladder. Prostatic hypertrophy in common is men, and diabetic neuropathy is a common cause in both sexes. I will end my live stream and I will continue this 12 midnight or maybe 10 in the evening. 10 evening or 12 midnight or maybe 1 in the morning. Alright, because my battery is low, 40%. Alright, to all my friends and viewers, small YouTuber, kindly watch my old video about health assessment for overview to part 4. Actually, part overview is my part 1, then part 2, part 3, part up to part up. So as of now, this is my live stream part 20, part 30 about health assessment in nursing. Thank you for viewing my live stream, to visiting my channel, my videos. Thank you. God bless you all. More blessings to come and more power. Bye-bye. God bless you.